Are you aware that in those with pain traveling down the leg due to lumbar disc prolapse, there may be a need for an emergency surgery within 48 hours under certain circumstances? Prolapsed disc refers to localized displacement of disc material beyond normal margins, resulting in inflammation of the nerve. This may cause pain and or numbness along the distribution of the nerve, and sometimes weakness in the muscle supplied by it. This generally takes place in the low back or lumbar region, but can sometimes do so also in the neck or the cervical region. The pain may come down along the leg or along the arm and forearm. The disc generally bulges towards one side. However, if it does so centrally, it may affect the nerves responsible for bladder, bowel and sexual function. This is called as cauda equina syndrome and is the only absolute indication for surgery. How is prolapsed disc investigated and how is the diagnosis done? What is the conservative management? What are the indications for surgery? To know this and a lot more, tune in to the Spine Wellness and Care Foundation's webinar this Friday, that is 3rd February at 7 p.m. Do you have a friend who has been suffering from leg pain or arm pain for a very long time? Have you or your friend tried to wonder why this pain has stretched for so long and there has been no respite? Let's try to analyze this with the example of a typical case scenario which visits our outpatient clinic. Mr. X visited us with history of leg pain since the last 2.5 years. It started with back pain. He went to a local physician who prescribed him anti-inflammatories, some hot fermentation, some gel and physiotherapy. He responded, but the pain came back after 3 months and started also traveling down the leg. He went back to the same physician but did not respond to the treatment. So then he went to another spine surgeon who told him that it was nerve pain and prescribed some medications to reduce the inflammation around the nerve, along with some physiotherapy and other treatment. He responded, but after 4 months the pain came back and he has been suffering again and again, and the treatment has been ongoing again and again. He is miserable. His job is at stake because he has to take prolonged leaves. Friends, you know what is the cause for this pain stretching for so long? Probably he has just been treated for the symptoms and nobody has tried to address the cause and take care of it. So friends, to know about what would be the most appropriate treatment, join us for the webinar on prolapsed intervertebral disc tomorrow at 7 p.m. See you. Are you aware that in those with pain traveling down the leg due to lumbar disc prolapse, there may be a need for an emergency surgery within 48 hours under certain circumstances? Prolapsed disc refers to localized displacement of disc material beyond normal margins, resulting in inflammation of the nerve. This may cause pain and or numbness along the distribution of the nerve and sometimes weakness in the muscle supplied by it. This generally takes place in the low back or lumbar region, but can sometimes do so also in the neck or the cervical region. The pain may thus travel down along the leg or along the arm and forearm. The disc generally bulges towards one side. However, if it does so centrally, it may affect the nerves responsible for bladder, bowel and sexual function. This is called as cauda equina syndrome and is the only absolute indication for surgery. How is prolapsed disc investigated and how is the diagnosis done? What is the conservative management? What are the indications for surgery? To know this and a lot more, tune in to the Spine Wellness and Care Foundation's webinar this Friday, that is 3rd February at 7 p.m. Do you have a friend who has been suffering from leg pain or arm pain for a very long time? Have you or your friend tried to wonder why this pain has stretched for so long and there has been no respite? Let's try to analyze this with the example of
पीपीटी है ना चल रही है इसका प्रिंट आउट भी निकाल
Mr. X
पीपीटी हाँ जो
has
प्रेजेंटेशन
of leg pain in the last 2.5 years. It started with back pain. He went to a local physician who prescribed him anti-inflammatories, some hot fermentation, some gel and physiotherapy. He responded, but the pain came back after 3 months and started also traveling down the leg. He went back to the same physician, but could not respond to the treatment. So then he went to another spine surgeon who told him that it was nerve pain and prescribed medications to reduce the inflammation around the knee, along with some physiotherapy and other treatment. He responded, but after 4 months the pain came back and he has been suffering again and again, and the treatment has been ongoing again and again. He is miserable. His job is at stake because he has to take prolonged leaves. Friends, you know what is the cause for this pain stretching for so long? Probably he has just been treated for the symptoms and nobody has tried to address the cause and take care of it. So friends, to know about what would be the most appropriate treatment, join us for the webinar on prolapsed intervertebral disc tomorrow at 7 p.m. See you. Are you aware that in those with pain traveling down the leg due to lumbar disc prolapse, there may be a need for an emergency surgery within 48 hours under certain circumstances? Prolapsed disc refers to localized displacement of disc material beyond normal margins, resulting in inflammation of the nerve. This may cause pain and or numbness along the distribution of the nerve, and sometimes weakness in the muscle supplied by it. This generally takes place in the low back or lumbar region, but can sometimes do so also in the neck or the cervical region. The pain may thus travel down along the leg or along the arm and forearm. The disc generally bulges towards one side. However, if it does so centrally, it may affect the nerves responsible for bladder, bowel and sexual function. This is called as cauda equina syndrome and is the only absolute indication for surgery. How is prolapsed disc investigated and how is the diagnosis done? What is the conservative management? What are the indications for surgery? To know this and a lot more, tune in to the Spine Wellness and Care Foundation's webinar this Friday, that is 3rd February at 7 p.m. Do you have a friend who has been suffering from leg pain or arm pain for a very long time? Have you or your friend tried to wonder why this pain has stretched for so long and there has been no respite? Let's try to analyze this with the example of a typical case scenario which visits our outpatient clinic. Mr. X visited us with history of leg pain since the last 2.5 years. It started with back pain. He went to a local physician who prescribed him anti-inflammatories, some hot fermentation, some gel and physiotherapy. He responded, but the pain came back after 3 months and started also traveling down the leg. He went back to the same physician but did not respond to the treatment. So then he went to another spine surgeon who told him that it was nerve pain and prescribed some medications to reduce the inflammation around the nerve, along with some physiotherapy and other treatment. He responded, but after 4 months the pain came back and he has been suffering again and again, and the treatment has been ongoing again and again. He is miserable. His job is at stake because he has to take prolonged leaves. Friends, you know what is the cause for this pain stretching for so long? Probably he has just been treated for the symptoms and nobody has tried to address the cause and take care of it. So friends, to know about what would be the most appropriate treatment, join us for the webinar on prolapsed intervertebral disc tomorrow at 7 p.m. See you. Are you aware that in those with pain traveling down the leg due to lumbar disc prolapse, there may be a need for an emergency surgery within 48 hours under certain circumstances? Prolapsed disc refers to localized displacement of disc material beyond normal margins, resulting in inflammation of the nerve. This may cause pain and or numbness along the distribution of the nerve, and sometimes weakness in the muscle supplied by it. This generally takes place in the low back or lumbar region, but can sometimes do so also in the neck or the cervical region. The pain may thus travel down along the leg or along the arm and forearm. The disc generally bulges towards one side. However, if it does so centrally, it may affect the nerves responsible for bladder, bowel and sexual function. This is called as cauda equina syndrome and is the only absolute indication for surgery. How is prolapsed disc investigated and how is the diagnosis done? What is the conservative management? What are the indications for surgery? To know this and a lot more, tune in to the Spine Wellness and Care Foundation's webinar this Friday, that is 3rd February at 7 p.m. Do you have a friend who has been suffering from leg pain or arm pain for a very long time? Have you or your friend tried to wonder why this pain has stretched for so long and there has been no respite? Let's try to analyze this with the example of a typical case scenario which visits our outpatient clinic. Mr. X visited us with history of leg pain since the last 2.5 years. It started with back pain. He went to a local physician who prescribed him anti-inflammatories, some hot fomentations, some gel and physiotherapy. He responded, but the pain came back after 3 months and started also traveling down the leg. He went back to the same physician but did not respond to the treatment. So then he went to another spine surgeon who told him that it was nerve pain and prescribed some medications to reduce the inflammation around the nerve, along with some physiotherapy and other treatment. He responded, but after 4 months the pain came back and he has been suffering again and again, and the treatment has been ongoing again and again. He is miserable, his job is at stake because he has to take prolonged leaves. Friends, you know what is the cause for this pain stretching for so long? Probably he has just been treated for the symptoms and nobody has tried to address the cause and take care of it. So friends, to know about what would be the most appropriate treatment, join us for the webinar on prolapsed intervertebral disc tomorrow at 7 p.m. See you. Are you aware that in those with pain traveling down the leg due to lumbar disc prolapse, there may be a need for an emergency surgery within 48 hours under certain circumstances. Prolapsed disc refers to localized displacement of disc material beyond normal margins, resulting in inflammation of the nerve. This may cause pain and or numbness along the distribution of the nerve and sometimes weakness in the muscle supplied by it. This generally takes place in the low back or lumbar region, but can sometimes do so also in the neck or the cervical region. The pain may thus travel down along the leg or along the arm and forearm. The disc generally bulges towards one side. However, if it does so centrally, it may affect the nerves responsible for bladder, bowel and sexual function. This is called as cauda equina syndrome and is the only absolute indication for surgery. How is prolapsed disc investigated and how is the diagnosis done? What is the conservative management? What are the indications for surgery? To know this and a lot more, tune in to the Spine Wellness and Care Foundation's webinar this Friday, that is 3rd February at 7 p.m. Do you have a friend who has been suffering from leg pain or arm pain for a very long time? Have you or your friend tried to wonder why this pain has stretched for so long and there has been no respite? Let's try to analyze this with the example of a typical case scenario which visits our outpatient clinic. Mr. X visited us with history of leg pain since the last 2.5 years. It started with back pain. He went to a local physician who prescribed him anti-inflammatories, some hot fomentations, some gel and physiotherapy. He responded, but the pain came back after 3 months and started also traveling down the leg. He went back to the same physician but did not respond to the treatment. So then he went to another spine surgeon who told him that it was nerve pain and prescribed some medications to reduce the inflammation around the nerve, along with some physiotherapy and other treatment. He responded, but after 4 months the pain came back and he has been suffering again and again, and the treatment has been ongoing again and again. He is miserable, his job is at stake because he has to take prolonged leaves. Friends, you know what is the cause for this pain stretching for so long? Probably he has just been treated for the symptoms and nobody has tried to address the cause and take care of it. So friends, to know about what would be the most appropriate treatment, join us for the webinar on prolapsed intervertebral disc tomorrow at 7 p.m. See you.
I mean, I can't imagine.
That in those with pain traveling down the leg due to lumbar disc prolapse, there may be a need for an emergency surgery within 48 hours under certain circumstances. Prolapsed disc refers to localized displacement of disc material beyond normal margins, resulting in inflammation of the nerve. This may cause pain and or numbness along the distribution of the nerve and sometimes weakness in the muscle supplied by it. This generally takes place in the low back or lumbar region, but can sometimes do so also in the neck or the cervical region. The pain may thus travel down along the leg or along the arm and forearm. The disc generally bulges towards one side. However, if it does so centrally, it may affect the nerves responsible for bladder, bowel and sexual function. This is called as cauda equina syndrome and is the only absolute indication for surgery. How is prolapsed disc investigated and how is the diagnosis done? What is the conservative management? What are the indications for surgery? To know this and a lot more, tune in to the Spine Wellness and Care Foundation's webinar this Friday, that is 3rd February at 7 p.m. Do you have a friend who has been suffering from leg pain or arm pain for a very long time? Have you or your friend tried to wonder why this pain has stretched for so long and there has been no respite? Let's try to analyze this with the example of a typical case scenario which visits our outpatient clinic. Mr. X visited us with history of leg pain since the last 2.5 years. It started with back pain. He went to a local physician who prescribed him anti-inflammatories, some hot fermentation, some gel and therapy. He responded, but the pain came back after 3 months and started also traveling down the leg. He went back to the same physician but did not respond to the treatment. So then he went to another spine surgeon who told him that it was nerve pain and prescribed some medications to reduce the inflammation around the nerve, along with some physiotherapy and other treatment. He responded, but after 4 months the pain came back and he has been suffering again and again, and the treatment has been ongoing again and again. He is miserable, his job is at stake because he has to take prolonged leaves. Friends, you know what is the cause for this pain stretching for so long? Probably he has just been treated for the symptoms and nobody has tried to address the cause and take care of it. So friends, to know about what would be the most appropriate treatment, join us for the webinar on prolapsed intervertebral disc tomorrow at 7 p.m. See you. Are you aware that in those with pain traveling down the leg due to lumbar disc prolapse, there may be a need for an emergency surgery within 48 hours under certain circumstances. Prolapsed disc refers to localized displacement of disc material beyond normal margins, resulting in inflammation of the nerve. This may cause pain and or numbness along the distribution of the nerve and sometimes weakness in the muscle supplied by it. This generally takes place in the low back or lumbar region, but can sometimes do so also in the neck or the cervical region. The pain may thus travel down along the leg or along the arm and forearm. The disc generally bulges towards one side. However, if it does so centrally, it may affect the nerves responsible for bladder, bowel and sexual function. This is called as cauda equina syndrome and is the only absolute indication for surgery. How is prolapsed disc investigated and how is the diagnosis done? What is the conservative management? What are the indications for surgery? To know this and a lot more, tune in to the Spine Wellness and Care Foundation's webinar this Friday, that is 3rd February at 7 p.m.
Hello, good evening. Hi, Venkatesh.
Hello, sir. Can you hear me?
Hi,
Yeah, I
Ajay.
can hear you quite clear. Good evening, sir.
Hi, good evening. All set. Thanks for joining.
Thank you,
My
sir.
We'll
pleasure,
start
sir.
sharp at 7, right?
Yes, sir.
नहीं, इसमें साइड में आता है शायद। चलो ठीक है। ठीक, फेसबुक लाइव कर। म्यूट कर। Friends, welcome to the next in the series of the Spine Wellness and Care Foundation's webinar on prolapsed intervertebral disc. We'll be starting in a minute. We'll request those who are not speaking to kindly keep their devices on mute, except the faculty who could keep their microphone on throughout the webinar. Those who have any queries in between may kindly type them in the chat box, and we will get back to you either within or at the end of the webinar for sure. And at the end of the webinar, you'll be able to ask your questions live directly to the panelists. So welcome once again. We are aware that back pain is the second most common ailment globally. 80 to 85% of people will suffer a significant low back pain episode at some point of their lifetime. Nearly 70% of them will have a recurrence within 1 year of the initial episode. This is responsible for the highest number of man-hours lost in the industry in US. Back pain causes an estimated loss of 800,000 disability-adjusted life years globally every year. The economic burden of back pain is estimated to be between 1 to 2% of the gross national product in Western nations. In US, economic burden is calculated at more than $100 billion annually. So that is the impact of back pain per se. India is no different. We have a very high prevalence rate, and especially in those in high-risk occupations. There are various causes of back pain. The most common cause of back pain is mechanical. So sprains and strains account for the most common cause of back pain. However, prolapsed intervertebral disc is also a common cause. In fact, Schwarzer et al. In their pioneering work attributed origin of chronic low back pain to intervertebral discs in 39% of the patients. So friends, let's see a couple of typical case scenarios of patients who visit us in our outpatient clinic. I am sure my colleagues, the panelists, also share a common experience. A 42-year-old gentleman, an IT professional, had low back pain radiating to the left leg off and on since 2 years. During acute episodes, is unable to walk even more than 10 steps, has had no bladder or bowel symptoms, has tried various treatment options, including medications, physiotherapy, fomentation, gel locally, injections, acupressure, and acupuncture. He responds temporarily, but keeps having recurrent episodes. He's frustrated. His job is at stake because he has taken too many leaves. His relationship with his wife as well as family is getting affected because he has become short-tempered. He gets angry very quickly. So friends, there has been a big impact on this individual, and we see such cases every day in our outpatient clinic. I believe my colleagues agree with me. So what would be the ideal management and treatment of such patients? Let's see another case scenario. A 30-year-old gentleman, a teacher, has low back pain radiating to both legs since 3 months. He is unable to walk more than 50 steps. However, he has developed recently urinary straining. He needs to apply pressure for voiding urine, and often the voiding time is delayed. He also has decreased sensations in the perianal and perineal region. So in this case scenario, will the treatment differ? Then from that in the first case scenario, we'll learn this and a lot more in the webinar today. Since prolapsed intervertebral disc and back pain are so common we thought about organizing this webinar on prolapsed intervertebral disc to create more awareness about how we can prevent it and how we can manage it. And friends, we are honored by having two very esteemed panelists who will be discussing about various aspects of prolapsed intervertebral disc management. Dr. K. Venkatesh is professor in the Department of Spine Surgery at Christian Medical College, Vellore. You are all aware about this prestigious institute. Moreover, he is a very passionate academician and researcher and is involved with us in a lot of academic programs and is a very core member of the Association of Spine Surgeons of India. Also joining us is Dr. Ajay Shetty from Coimbatore. He's a senior consultant in spine surgery at Ganga Medical Center and Hospitals Private Limited. He's the chairman of AO Spine India and board member of Asia Pacific Spine Society. He's an associate editor, Journal of Orthopedics and Journal of Musculoskeletal Disorders. So welcome Ajay and welcome Dr. Venkatesh to this webinar. We will.
Thank you very much, sir.
Hi. So we will start with the first question to the panelists, and we will address this first to Dr. Venkatesh. Dr. Venkatesh, what do you understand? How would you explain disc prolapse to our friends who have joined us for this webinar?
Thank you very much, sir. To start with, disc is a cushion-like structure. You can see here. So this is the two spinal bones, and you can see a cushion-like structure. Oh, sorry. Can you hear me, sir?
Can hear you, Venkatesh.
Yeah. So cushion-like structure, which is situated between two bones, basically it acts like a shock absorber. And this cushion is actually made up of a tough outer layer, which is called the annulus fibrosus, and a soft gel-like an inner layer, which is called the nucleus pulposus. So what happens is because of repeated strain or because of injury, wear and tear, degeneration, there is a tear in the outer layer, that is in the annulus fibrosus, which expels the soft core gel, which is the nucleus pulposus outside. This is called a prolapsed intervertebral disc.
Thanks, Venkatesh. Could you please show that model once again and explain on that to our viewers here?
Yeah, you can see here. So once again, I'm telling you, so these are the white things are the bone, and in between you have the cushion-like structure, which is called the disc. So, and this disc has an outer layer, which is the tough outer layer, and it's a soft inner layer, which is gel-like structure. So because of repeated wear and tear or because of injury, there is a tear in the outer layer, which pushes the inner soft core of gel or the nucleus pulposus outside. And usually it's called as the disc prolapse.
Thank you, Venkatesh. Thank you, Dr. Venkatesh. I believe one of our participants is having problem in not being able to hear us properly.
Yeah.
We would request you to leave the webinar and join again because there may be some audio connection issues per se, and you will be able to hear it properly. So Ajay, Venkatesh explained what is prolapsed disc very wonderfully. Do you have anything to add to that? Please unmute yourself as you speak.
Actually, Dr. Venkatesh has explained very beautifully. The fact that people presume that the prolapsed disc means the whole disc will prolapse. But basically, as he mentioned, it has got two components. The outer fiber becomes weaker and the inside jelly comes out, and when it comes posterior to that is the spinal canal, which contains the nerve roots. And when it compresses the nerve roots, an individual can have a back pain or a leg pain.
Thank you, Ajay. I hope all the viewers are able to hear properly now. So, explained very wonderfully by Dr. Venkatesh and Dr. Ajay. And this has been defined by various associations across the globe. But in layman language, just to reinforce so that we understand the topic properly, it is a localized displacement of disc material beyond the normal margins of the intervertebral disc. And this results in inflammation of the nerve which is exiting just behind it, which may result in pain or numbness or both of them along the distribution of the nerve, and sometimes also weakness of the muscles supplied by it. So this is more or less what has been described. Moving forward, I want to ask Dr. Ajay, what are the symptoms of disc prolapse?
The disc prolapse, it could be asymptomatic. Sometimes when we incidentally take an MRI for some other reasons, we might notice the disc prolapse. Actually, a lot of times it could be asymptomatic. But most of the time when the patient presents to us, they can present with a back pain. Usually the patient says that he bent to lift a weight, or he suddenly coughed or sneezed. There is a catch in the back and he walks with a stiff back, or sometimes the body is slightly bent. That is one of the commonest presentation. The second way of presentation is that they can present with the back pain which goes down to the legs, to the calf. It's like because basically when the disc comes out, it might press on the nerves, and the nerve from the back comes down to the legs. Wherever the nerves go, you might perceive pain. It's like an electrical wire. You put the switch here and you might see the light elsewhere. The same way, when the nerve is being compressed, you may get a pain along the radiation. These two are the most commonest way of presentation.
Thank you, Dr. Ajay. Dr. Venkatesh, do you have anything to add, especially where exactly does the pain travel? Can the disc prolapse happen also in the cervical spine as it can in the lumbar spine?
So as you notice, as Dr. Ajay said, that usually the disc comes out through the ruptured or the torn annulus, which is the tough outer layer. And if you see here on the back, okay, so you can see this is the spinal canal, okay, and these are the nerve roots. You can see these nerve roots here. So when the disc prolapses, okay, usually what happens is the weakest part of the disc is usually in the posterolateral part, that is on the back and on the outer aspect, which is closer to this nerve root. So when it ruptures here, the nucleus pulposus comes out, and or a part of the fiber, annulus fibrosus, also comes out and starts pressing this nerve. So these nerves are part of a large nerve called the sciatic nerve. So that is why the disc prolapse, it's commonly called as, the pain is commonly called as sciatic pain when it happens in the lumbar region. So these nerves are part of this large nerve, which is sciatic nerve, and the pain travels along the course of the sciatic nerve, which is in your leg, on the back of the leg. So the same thing can happen in the cervical spine, in the neck. So in the neck, when it happens, the same thing, it is part of a nerve called brachial plexus. So, and it can cause something like a brachialgia. That means the brachial nerve pain or the arm pain, on the hand pain, it can happen. Since in this cervical spine, you have something called the spinal cord also there. So if it compresses the spinal cord, it can produce weakness of the upper limbs and on the lower limbs. So usual symptoms are, as Dr. Ajay said, is the back pain, which is very common. And sometimes they can have radiating leg pain, which is called the sciatic pain in the lower limbs, and brachial pain, which is in the upper limbs.
Thank you, Dr. Venkatesh and Dr. Ajay. You have described very wonderfully. Just to reinforce for the sake of our participants with the help of some diagrams and graphics, generally, when the disc prolapse takes place in the lower back or the lumbar region, you may have pain traveling down along the distribution of the nerve in the leg. It may be along the whole distribution, or it may be just in the buttock or just in the calf, right? And it is more on sitting, standing with a tilt. Leg pain, as we said, is along the distribution of the nerve. People are unable to walk long distances, and people may get relieved with the hip and knee in the bent position because it relaxes the pressure on the nerve. As Dr. Ajay and Dr. Venkatesh mentioned, sometimes there may be only back pain due to the disc prolapse. Again, the onset is after exertion. Pain is more on forward bending, and it's aggravated by coughing and sneezing. As was also described, because the disc is all along in the spine, but because of the movements which take place in the neck region and in the lower back, the disc prolapse happens more often in the lower back because of the weight above it, lesser often in the neck, right? Because and here with the disc prolapse, the pain may travel along the distribution of the nerve in the arm, forearm, and hand. It's relieved by raising the hand above the head. And as Dr. Venkatesh said, when there is a central disc prolapse which presses on the spinal cord, there may be signs of spinal cord compression. The hand functions may get affected. People may have difficulty in buttoning the shirt, in writing. There may be imbalance while walking. There may be difficulty in climbing stairs. There can be tingling, numbness, burning sensation. There may be decreased sensation. There may be weakness of a muscle supplied by the nerve. And you may see like weak muscles of the calf or the hand also in cases of chronic disc prolapse. And rarely, not very often, but this can take place in 2 to 3% of patients with a lumbar disc prolapse, and also with cervical myelopathy, that is pressure on the spinal cord in the cervical region. The nerves which control bowel and bladder function, they get affected, and there may be straining to pass urine, or the urine keeps dribbling per se. There may be increased urinary frequency or urgency. There may be decreased sensation in the area around where the stool passes or in the whole private part. There may be difficulty in controlling stool, and there may be decreased contractions of the anus or the area from which the stool passes out. So these take place generally when the disc protrudes centrally and compresses the nerves to the S2, 3, 4 nerves, which control bladder and bowel function. Now coming again to Dr. Venkatesh. Dr. Venkatesh, how is prolapsed disc diagnosed? How do we say this is a patient of prolapsed disc?
So intervertebral disc prolapse is usually a clinical diagnosis, then followed by doing some imagings or investigations to confirm it. So as previously said, usually they come with back pain, and they come with a radiating leg pain, which is called a sciatic pain. So most of these patients, they will have severe back pain, and on examining their back, they can have muscle spasms. That means the muscles can be tight or taut on either side, or sometimes on both sides. They will have local tenderness. That means on pressing that tight muscle or the taut muscle, they can have severe pain, or sometimes when you give thrust to this region, they can have severe pain. And if you ask the patient to bend forwards or backwards, they will have excruciating pain. So all these things are going to tell you there is some problem which is happening in the lower back. And with the history, you can say that probably it is a disc which is got ruptured. Then coming back to the leg, going to the legs, that they will have a shooting or radiating leg pain. And usually it is from the top to bottom, that is from the upper end to the lower end. It usually goes along the buttock and on your thigh and on the leg, on the feet, whether it is in the front or in the back or in the sole. They may have associated, as I said, tingling sensation or loss of sensation or altered sensation, either in a particular region, that means one band-like region, or in the whole of the leg. So this will help us to differentiate. As you said, there are many other conditions which can produce similar things like diabetes, something called aneurysms. All those things can produce a similar picture which can be differentiated. Also, in people who are smokers, they can have this kind of a pain, which can be differentiated with the pattern of pain, leg pain, what they have. So once we know that this is a sciatic pain or a lumbosacral radicular pain, which is probably due to the disc prolapse, we do some special tests on these patients. So we do something called a straight leg raising test. That means you stretch the nerve and it is going to reproduce the pain, or the pain is going to be slightly increased because of that stretch. So you make the patient lie down and lift the leg with the knees extended, the knees kept straight. They will reproduce the pain which is going in the back. In few people, apart from numbness and tingling, they can have weakness of the muscles which are supplied by these nerves, which can be examined. Like these patients can have difficulty in lifting their foot, ankle. That is, they can have something like a weakness of the dorsiflexors or the ankle, or they can have weakness of the toes, where they might find difficulty in holding their slippers. So these are some of the other things which will tell you that probably it is a prolapsed intervertebral disc prolapse. Very, very rarely they will come with bladder or bowel or sexual dysfunction due to a massive central disc prolapse. So these are the ways we can clinically identify a disc prolapse.
Thank you, Dr. Venkatesh. Ajay, do you have anything to add to what Venkatesh has mentioned? You're muted, Ajay.
I don't think I can add anything for that. But in the upper limb, the presentation would be slightly different. Therefore, they usually presents with neck pain. And most of the time, they come with an arm pain. They sometimes comes to the outpatient keeping the hand like this. I mean, that's only very characteristic of it. Sometimes they might say that the fingers or the thumb is numb. Therefore, in the upper limb also, similarly to the low back, they present with neck pain and a lot of times shooting towards the hand. There could be weakness in the hand. And very, very rarely, sometimes the disc is very huge. They can come with weakness of all the four limbs. It's more of a clinical suspicion. And then we ask for investigations. It could be in the form of a radiograph or a MRI scan.
Thank you, Ajay and Venkatesh. That was wonderfully explained. As mentioned, just for the sake of reinforcing, the condition is mainly diagnosed with the classical history and clinical examination findings. Mind you, the diagnosis is not with the investigations. Very often people come to us with investigations in their hand. My uncle is suffering from this. You can see that on the MRI. How do you manage it? No, the diagnosis is on the basis of a history and clinical examination. The distribution of pain, paresthesias, or weakness along the distribution of the nerve is classic. As Dr. Venkatesh mentioned, as you can see here, if you lift the leg, the nerve gets stretched. This is called a straight leg raising test. And especially if you have pain traveling down one leg and the pain is simulated by lifting the other leg, then it is classic and represents more severe disc prolapse. That is what we call as a cross SLR test. In cases of cervical myelopathy, where there is pressure on the spinal cord, there will be other signs and symptoms with which you will be able, a clinician should be able to diagnose. But we mentioned about the symptoms which could be characteristic of this. And in fact, some of these tests put together are very specific, as high as 95% specific for diagnosis. So I would put the next question to Dr. Ajay Shetty. What are the investigations for prolapsed disc?
The first investigation is probably a plain radiograph, that is an X-ray. By X-ray, we may not be able to find out whether the patient has got a disc prolapse, but it's important to rule out conditions which can mimic or which are very, very significant, like an infection, like tumors, like a break in the bone called lysis and listhesis. That's what we are looking for when we do a plain radiograph. When the disc is completely degenerated, the disc height might be decreased. But to diagnose somebody with a significant whose pain does not subside with medications for a short duration of time, then we would ask for a MRI scan. CT scan is usually not preferred in the initial mode of investigation. What is preferred is basically the MRI scan, which will help us to identify our clinical diagnosis, whether it is correct or not, and at what level, what type of disc prolapse, everything can be seen in the MRI.
R.K. Batra ji has a question. He has raised his hand. Can you put across the question, please? You could unmute yourself now, please. Batra ji, do you have a question? If you have one, you can unmute, or if you want to just type in the chat box, we'll get back to you. So you please unmute yourself. Unmute.
Question लिखे थे.
We'll get back to you subsequently. We will just carry on right now. Please see, you can also type your questions in the chat box per se. Dr. Venkatesh, do you have anything to add to the investigations as mentioned by Dr. Ajay Shetty?
So many a times people will be wondering why the doctor is asking for an X-ray when I have this pain. Why can't we directly do an MRI? So the answer to this is like not all disc prolapses need a major treatment. So it can, just as Dr. Ajay said, that is basically we are trying to rule out other things, and before doing an MRI, we can treat this patient conservatively and see. So that is the whole idea of doing the X-ray on these patients. And also these patients sometimes can come with a repeated remission and exacerbation. So that's a classical finding. Like they have many times that they will have these symptoms and it will settle on their own. And again, some other stimulus, it will cause the pain again. And again, it will settle on their own. But the frequency and intensity will keep on changing.
Ajay, do you ever rely on special investigations like nerve conduction, velocity study, electromyography, or somatosensory evoked potentials? Do you ever need them in the management of a prolapsed disc?
Usually not. In very rare situations, when the clinical finding is not very suggestive of a lumbar disc prolapse, when we are thinking in terms of a diabetic neuropathy, then a nerve conduction study would be useful. But in majority of the patient, a patient who comes to us with a back pain, with the pain radiating down to the leg, with a classical SLR, and MRI shows evidence of a disc prolapse is not necessary. Only when the diagnosis is not sure, when there is a bilateral limb involvement, whether there is a burning type of pain more in the night, we would resort to a nerve conduction study.
Thank you, Ajay, and thank you, Dr. Venkatesh. So you have very well described the investigations which may be done for diagnosis of a prolapsed intervertebral disc. In fact, not for the diagnosis, but for reinforcing the diagnosis or confirming the diagnosis that is made on the basis of a good history and evaluation per se. The MRI is one of the most accurate tests and generally has a significant role in deciding further plan of management if the conservative treatment fails. CT myelography, as was said, may sometimes be required in patients where an MRI is contraindicated. Sometimes a pacemaker, which is not compatible to an MRI, there a CT myelography may be required. Special investigations are generally not required, as only used, as Dr. Ajay Shetty said, when you need to rule out other conditions like a diabetic neuropathy. And the nerve conduction study have limited utility in the diagnosis. Somatosensory evoked potentials are also very less often used per se. So I see Poonam ji raising her hand. If you have a question, please unmute yourself and please put the question across. Yes, Satyapal Gupta ji, Virat Gupta ji, please
Yeah,
ask.
Dr. Satyavrat Gupta.
Yeah, Dr. Satyavrat Gupta, sorry. Yeah, please.
I'll be comfortable if I'm allowed to speak in Hindi.
Sure, definitely.
Yes, sir.
सर मेरे को पिछले 2015 से यही प्रॉब्लम शुरू हुई. मैं आपको पहले कंसल्ट किया था और मेरे को शाटिका सिर्फ लेफ्ट में थी. ओवर ए पीरियड एक्सरसाइज वगैरह करके वो दैट इज सबसाइडेड. अभी मेरे को इतना जैसा आपने अभी एक्सप्लेन किया बोथ द डॉक्टर्स, मेरा डाउन द लाइन बड़ा पेन हो रहा है और मैंने कल की आपसे राहुल जी से बड़ी रिक्वेस्ट करके अपॉइंटमेंट भी ली है. आई विल बी कमिंग टू यू फॉर द इन्वेस्टिगेशन. पर मेरे को सबसे ज्यादा डर लगता है ऑपरेशन से. तो उसके लिए एक जो मिथ है कि ये बहुत ही सेंसिटिव प्लेस है जहां उसको सर्जरी होती है और आपको फॉर डेज पेट के बल लेटना पड़ता है और सो ऑन. मतलब आई विल कम एंड एक्सप्लेन इट टू यू द काइंड ऑफ fear I have for this kind of a surgery. But I am really suffering. I am 65-year-old. I am leading a retired life now. But position is I am not in a position to stand for more than 2 minutes.
डॉक्टर सत्यगुप्ता, आपने अगर आप थोड़ी देर वेट करेंगे आपको अपने सवाल का जवाब अपने आप मिल जाएगा, क्योंकि अभी हम मैनेजमेंट पे आने वाले हैं. दूसरा, आपने बिल्कुल ठीक बोला कि बहुत सारी मिथ्स हैं सोसाइटी में, और ये भी एक मिथ है कि अगर सर्जरी करवाएं तो उससे बहुत प्रॉब्लम आ सकती है. तो हम आपके सवाल का जवाब थोड़ी देर में जरूर देंगे. पूनम जी, आप कुछ पूछना चाहते हैं?
राइट सर, थैंक यू.
थैंक यू. पूनम जी, आपने हाथ उठाया था, कुछ आप पूछना चाहते हैं? तो if not, we will move forward, and please feel free to write down your question in the chat box. We'll come back to you with the answers of the question. Coming to the next question, which I will put across to Dr. Venkatesh. Dr. Venkatesh, what is the conservative treatment for prolapsed disc? And if you see a patient of a disc prolapse, how would you initiate the treatment?
Yeah, as you said, as Dr. Chabra said, that the only absolute indication for operating a disc prolapse is something called a Cauda equina syndrome. That means the patient has bladder, bowel, and dense sensory and weakness of the lower limbs. All the other disc prolapses, almost 85 to 90% of the disc prolapses can be treated conservatively or non-operatively. So the main principles in treating these patients conservatively are: one is pain relief. Pain relief means back pain relief, and the next one is leg pain relief. And the next one is getting back to their function, early function. The last one is preventing recurrence. That means these problems coming again. So looking one by one, so how do you address back pain? So these patients come with excruciating back pain sometimes. So they need good analgesics, that is anti-inflammatory medications have to be given on these patients unless there is a contraindication, either because of renal failure or ulcer problems. If they have those kind of problems, then they can be given opioid, that is morphine kind of drugs, which will relieve the pain. So pain relief is very important. The next one is the leg pain. How do you address the leg pain? So these analgesics can give good relief for back pain, but for the nerve root irritation, you have to add something called a neural modulators. So there are many drugs available. The commonest one being used is pregabalin or gabapentin, sometimes carbamazepine, amitriptyline. There's a lot of these drugs are there, which the physician will decide based on the patient, the dose, and the amount of medications need to be taken and how long it has to be taken. So how long to take rest during this period? So rest is needed only till the acute symptoms are over. So once you start the treatment, that is your NSAIDs and the neural modulators, usually these pains settle somewhere between 3 to 4 days. So in 3 to 4 days, these pain settles. So only during this period, when you have an acute pain, you need rest. Okay, rest doesn't mean absolute bed rest, that you are not tied to the bed. It is your movements, movements are limited, that means supervised, that you can go to the toilet, you can take bath, you can sit and eat, whichever is comfortable you can do. It is not absolute bed rest. So once this pain in 3 to 4 days are settled, it comes down, then we are thinking back of
Yeah, Venkatesh. Yeah.
Yeah, so we are trying to get back to work, back to work. So it is after 3 to 4 days. So how to do this? Because when you start functioning now after 3 to 4 days, you may again get problems. So after 3 to 4 days or even after a week, we start something called isometric exercises. That means we are strengthening your muscles. See, disc prolapse is a degeneration. So you cannot regenerate the disc. So what we have to do is the function which is done by the disc has to be done by some other group of things which can supplement these functions, like the muscles. So these muscles are made strong so that this is going to help your degenerative disc to maintain the load or the pressure which you are going to give by your normal activities. So you have to strengthen these muscles by isometric exercises, which a good physiotherapist will teach you to start with. So these exercises usually takes 2 to 3 weeks to start acting on you. So technically speaking, after 3 or 4 days, you can get back to your normal activities. And after 3 or 4 weeks, you can go back to your normal work. So, and you try avoiding the works which have caused these pains. You may have to modify your lifestyle and keep on doing these exercises. Some people, yes, with severe back pain, usually we don't recommend a corset, but in some patients, it may help both for psychological support and also that additional support which can give you by strengthening holding the muscles together. So conservative management in this aspect can do in majority of these patients. So at 3 to 4 weeks, if you find that the conservative management is not giving full improvement, maybe the patient has had 50% improvement or 40% improvement, then we can do semi-invasive procedures. So these are called semi-invasive procedures like root blocks and epidural steroid injections. So what these do, they are not going to push your disc back, but they are going to take care of your disproportionate pain. Okay, the problem might be small, but your pain may be disproportionate. So these drugs, whatever we are giving directly over the nerve root, are going to alter the pain cycle, and then it is going to reboot the computer, that is reboot your mind to a different pain stimuli. So your pain usually comes down. So patients who have partial improvement, we try these kind of methods. So in 80 to 90% of the patients in 3 to 4 weeks, or at least in 6 weeks, the pain should come back to normal and they should return back to their normal activities.
Thank you, Dr. Venkatesh. I can see a question by Ranjit Kumar Jhaji that he has T11, T12 right leg and full body pain. He's asked for what he should do for treatment. We'll get back to you, Ranjit Kumarji, later. But T11, T12 disc prolapse is a totally different ballgame. It will cause the same symptoms like myelopathy due to a disc prolapse in the neck region, except the upper limbs or the hands will not be affected. We'll get back to you later on in the webinar. Meanwhile, Dr. Ajay Shetty, do you have anything to add to what Dr. Venkatesh has said regarding conservative treatment? What is your protocol of conservative treatment? Is it the same or does it differ?
I would agree with Venkatesh on this aspect. We have to realize that whatever treatment we are going to give is basically a symptomatic treatment and to tide over the pain during the acute phase. Body tries to heal itself. Whenever the inner part of the disc comes outside, there is a significant inflammation that sets in. And over a period of time, the inflammation will subside and the symptoms will subside. But till that period of time, there is a lot of pain. And what we are doing by treating is basically to take off the pain so that during the process when the body is trying to heal itself, the patient is relatively comfortable. We follow the same line of treatment. And if the patient doesn't become better with non-operative management, we tend to give a nerve root block. And that's what usually we practice.
Thank you, Ajay. I will just try to summarize what has been discussed by, pointed out by both of you. So the principles of treatment include treating the pain and try to reduce or remove the cause. So you have to reduce the recurrence rate also. That is also very important. And the vast majority, in my experience, 95 to 97% respond to a good conservative treatment. The treatment may be in the form of medications. There are various medications which may reduce the inflammation around the nerve, gabapentin, pregabalin, amitriptyline. Or these medications may cause drowsiness or giddiness, or may have other side effects when taken for a long term, like water retention, like some psychosis, etc. So always take them under the prescription of a doctor after understanding properly how you need to take these medications. And we in our practice would gradually increase the dose and reduce or substitute if there is drowsiness or giddiness or other side effects. In our practice, we also use steroids sometimes in patients with acute pain or those not responding to treatment. Some people would not use it, but it is well described in the literature. And as also mentioned by Dr. Venkatesh and Dr. Ajay, if people do not respond to medications, then you can give injections in the back. Basically, you put some steroid around the nerve roots and you may get some relief. But very often patients who do not respond to medications will respond to these injections, which may need to be repeated. You selectively block the nerve roots. The techniques for these injections have also improved over the period of time. Hot fomentation or ice packs, some people do better with heat, some do better with ice. You may try to find out by trial and error what suits you best. You may go to a therapist for some deep heat therapy like shortwave diathermy, microwave diathermy, interferential therapy. TENS therapy generally is used for radiating pain, and people respond well to that temporarily. And similarly, acupuncture and acupressure are other techniques which are open for temporary reduction of pain. Spinal manipulation also, there is evidence in the literature in this regard. Mechanical traction has been described and many people use it, though I generally do not use it in my practice because sometimes the pain may increase. And I tell my patients that if you go in for traction, if your therapist advises traction, you want to take it, you are not responding, take it. But if on the table your pain is increasing, ask them to stop immediately. And gone are the days when people used to be put on traction in the bed for days altogether per se. Lumbar stretching exercises, whichever don't increase your pain, neck exercises. And I think a very important component of the treatment is patient education, telling them what is the problem, how it will be managed, and how they can reduce the chance of recurrence is very important for them to comply, because sometimes the treatment stretches over a period of time and very often they need to follow lifestyle changes, which are actually nothing but a healthy lifestyle. But patient education has a definite role in the management of prolapsed intervertebral disc and back pain in particular. Also, long-term aerobic physical conditioning exercises have been shown to have a definite role in conservative treatment per se. So this was generally summarizing what is the conservative treatment. I would agree with Dr. Venkatesh. Using a corset cannot be taken as a blanket statement. In many patients, the pain may increase with the use of a corset. In many, it doesn't affect them in any way, but some patients may benefit temporarily with the use of a corset. They may use it if the pain is bothering them and if they can do their activities better with the use of corset per se. So this is in general the conservative management of prolapsed disc. And I would come to Dr. Ajay Shetty. Ajay, what are the indications for surgery? Are there any absolute indications for surgery? Venkatesh has already mentioned it, but for the sake of reinforcing, please highlight that as well.
If we have a disc prolapse, we need not be alarmed or worried about it. As mentioned in our discussion earlier, 90% of the patient will become better, and a lot of them will stay better. It's not necessary that we will get repeated episodes. You have to take certain precautions. But there are certain situations, about 5 to 10% of the patient may not respond to whatever conservative treatment we put, and we may have to think of surgery as an option. The most common reason why we do the surgery is basically because of persisting pain in spite of conservative care, which is disturbing the normal day-to-day activities of the patient, of the person. That is the most common cause. A pain which is persisting, disturbing his regular activities, is not able to go to work, then we may have to consider surgery, that too a period of conservative treatment of more than 6 weeks' time. Sometimes we may operate earlier when the patient has got a weakness which is significant. His foot drops, he's not able to move his foot. We might consider a surgery earlier. And an absolute indication, as mentioned earlier, is a huge disc prolapse, which has got weakness in the leg, which has got problem in passing urine and motion. The control of urine is lost, what is called as a cauda equina syndrome. That's an absolute indication, and that's an emergency indication. We try to operate as early as possible. Okay, these are the usual indications when we advise surgery for the patients.
Dr. Venkatesh, do you have anything to add to what Ajay has mentioned?
Yeah, I think Dr. Ajay has mentioned most of the things and all the things. So to put it in order, the most absolute indication first will be cauda equina syndrome. The next will be dense weakness. That means, as he said, as dense foot drop. The third one is like patients who are having excruciating pain, which is not settling with your conservative management for at least a period of 6 weeks. And next one is the patient has a recurrent pain. So the pain comes, it goes off, and then it comes again and it goes off. So it keeps on happening again and again, so that like in a year, at least 4 to 5 times he has to take rest. So that will be one of the other indications which we see. That means frequent pain which goes off and comes again.
Thank you, Dr. Venkatesh. Vinitji has asked, what are the precautions senior citizens should take in day-to-day life to avoid this situation? Does sitting cross-legged on floor also aggravate such conditions? Vinitji, we'll get back to you in a subsequent question. We are coming to it soon. So you'll get your answer soon in this regard. Meanwhile, carrying on with the discussion and reinforcing what has been just mentioned, generally the most common indications for surgery are relative indications. That is, if there is no or partial relief with a conservative treatment, then you would go in for surgical treatment. And here it's not just conservative treatment, it's an appropriate conservative treatment, which is very important. So if there is no relief with an appropriate conservative treatment and the condition is affecting the activities of daily living, it's leading to loss of time at work, one may go in for a surgical treatment. Absolute indications mentioned with involvement of bladder and bowel function, the control getting involved with, there would be generally numbness in the perineal region. Also, if the disc prolapse is in the neck and there is cervical myelopathy, that is pressure on the cervical spinal cord, and it is beyond a certain level, right? Not in all conditions, then you may go in for a surgical management per se. So I will come now to Dr. Venkatesh. What are the options of surgical management? What are the pros and cons of each? Then I will request Ajay to add on to what Dr. Venkatesh has said and also enumerate any indications of fixation and fusion which may be there in a case of a disc prolapse. So over to you, Dr. Venkatesh, first.
Thank you, sir. So if you see, once the patient is diagnosed and decided that you are going to have an operative management, so there is a big discussion, or it's a group discussion between the surgeon and the patient. So he has to understand that we are not going to set everything back to normal. So we are going to improve his quality of life. So that is the main thing. It is not like that you are going to make the disc normal. So we are going to improve the quality of life by taking out the prolapsed disc. It is not the whole disc. So that he should understand. So what is the implication of it? Means that the rest of the disc is there to give a good function for him. So, but he has to be careful. It is a damaged and diseased disc. So he should not make it worse again. So once he understands this, then there are a lot of options are there. The main thing is what we can, the classical thing is an open discectomy. That means you make a open midline incision and you elevate the muscles and you do something called a laminotomy or a laminectomy and then take out the disc prolapse. So this is an open procedure. So this open procedure can also be done with a microscope, which is called a microdiscectomy. So these are the two very common surgical procedures which are done, which is an open discectomy and a microdiscectomy. The other options are where you have something called an endoscopic discectomy. So where you use tubes inside and you do the same thing which is done through an open discectomy with through an endoscopic small portal where the magnification is done by a camera and which is seen on a monitor where you see a monitor and you operate this one. So this is an endoscopic discectomy. You can do something called a percutaneous discectomy, which is again an endoscopic discectomy. So these are the various options for a discectomy. Very rarely, there are some places where they do indications are there where you do a fusion surgery. That means you take out the whole disc and then fuse the spinal segments, which is very rare, and usually it is not done. And one more option which was there before, which is not very popular, is a lumbar disc replacement on these patients who have a disc prolapse. So, but the commonest one done are the open discectomy, followed by microdiscectomy, then followed by the various types of endoscopic discectomies.
Thank you, Dr. Venkatesh. Ajay, would you want to add to that and also try to highlight any pros and cons of each option which is there?
It's an evolution of surgical management. It started with the open discectomy, then came the microscopic, and now the current one is endoscopic discectomy. What is the major advantage of each one of these techniques? I mean, with the evolution, the endoscopic discectomy, the collateral damage, the damage to the muscles is relatively lesser. But however, when you look at the long-term results, the results have come up to 5 years. There is no major difference. It's only the short term. Immediately after surgery, for a period of 2 or 3 weeks, there is a definitive advantage in terms of pain. But however, in the long term, there is no major difference in outcome. That is the first important thing. Coming to the second thing, is it necessary to fuse? Majority of the time, as Dr. Venkatesh mentioned, we do not fuse when you are operating for a patient with a disc prolapse. We are speaking mainly of a lumbar disc prolapse. Whereas in a cervical disc prolapse, the treatment options would be slightly different. In the lumbar disc prolapse, we usually do not consider fusion as an option. Sometimes there could be an associated instability associated with disc prolapse, which is usually very rare. And that is the situation when you might consider fusion along with the disc prolapse.
Thank you, Ajay. Dr. Venkatesh, there's a question in the chat box. Dr. Komal Kamra wants to know a little more about disc replacement surgery.
Yeah. So disc replacement surgery is like your hip replacement or the knee replacement surgery, where the disc is taken out and an artificial disc is placed there. So the advantages of this procedure is like the offending structure, which is the disc, has been taken off. And instead of a fusion where it is going to reduce your movement, you are going to put an artificial disc material there, which is going to replace the function of the affected disc, the original disc. So basically, it is like getting back to normal. Okay, it's like your replacement. There are very few indications for this. Actually, a classical prolapsed disc, if you would have seen Dr. Chabra's first MRI, where there is a large disc which has come out, well, those patients are not for disc replacements. It is basically for these patients who have a bad disc with a minimal prolapse, but with a lot of pain, and their activity needs a lot of movement, and they are not improving with conservative management. So very few indications in young people, especially people who are less than 40, okay, where there is no arthritis in the back. So only disc is the offending structure and causing the problem. And they have failed a good conservative management in a good conservative setup. The patient in places where they have a good back school and where they have documented that this patient or this person has undergone a care.
I think we have lost Dr. Venkatesh temporarily, but Dr. Ajay, there's a question in the chat box and I'll ask you a related question. What is the outcome of a surgical management of disc prolapse? That is, do all of them respond very well? So what is your experience and what is there in the literature?
As per the literature and in my experience also, about 90 to 95% of the patients do respond very well to conservative treatment and also to surgical treatment. But however, irrespective of whatever we do, we're basically addressing the pathology, that is the disc which has come out and compressing the nerve root. Therefore, there is always a chances, about 5 to 10% chance, that the remaining part of the disc which is inside might come out again in the future, what is called as a recurrent disc prolapse. Okay, these are the only things. I mean, you can have infection, you can have nerve root injury during surgery, but that incidence is less than 1% or maybe 0.5%. The only thing what can happen is because the degeneration tend to progress with age. That is not something we can control. Therefore, there is always a chances of recurrence. But however, majority of the patients who undergo surgery do well and they stay well.
So there was a comment in the chat box. If I suffer with such illness, I will immediately go for surgery. So we need to understand that surgical management is not a guarantee, is not a magic wand that you will improve for sure. And it's not that if you undergo a surgery, the next day you'll be back to normal per se. So generally, it is advisable that unless absolutely indicated, go in for a conservative trial, and if you do not respond, then go in for surgical management. However, these are all individual preferences. Some people say, I'm losing $1 lakh a day because I'm not able to go back to work. I want to go in for a surgery directly. Fine, it is their choice, but they should understand the pros and cons of conservative and surgical management and take a considered decision together with the doctor in deciding the line of management. Would you agree with that, Ajay?
Sir,
Yes.
I definitely would agree to that aspect.
Right. So I think we have Dr. Venkatesh, you are back. Please carry on with what you were trying to say. We lost you temporarily.
Yeah, so I was talking about disc replacement. So it is mainly done for young people who are less than 40 years of age, who has failed a good conservative management, documented by a good conservative school, conservative line of school, that's like a back school. And these patients, usually they should not have any arthritis in the back. So for young people, and usually it is done from the front through the abdomen, where the offended disc is taken out and a new disc, artificial disc is replaced there. It used to be very popular back in the 2008, 9, 10 and all those things. Now it is not very popular because people find that that people who go for a regular discectomy or with a back school treatment, they also do well. So it is kept as a last reserve for very young people who are really failing on conservative managements.
So there is another comment in the chat box. Rheumatoid, I'm a rheumatoid patient. There's no treatment for spondylitis L5, S1, tilted backbone with alignment problems. I think we'd want to say that gone are the days when there was no treatment for any such condition. We would strongly suggest that you consult your clinician or your spine surgeon. There is definitely treatment available for this, and there are good treatments available to give you respite. But since it is beyond the scope of this webinar, we'll not be going into depth discussing this in depth, except if we have some time towards the end of the webinar per se. Another question, Ajay, what is the role of muscle relaxants for prolapsed intervertebral disc? Vijay Jainji wants to ask that.
The role of muscle relaxants is basically when the back pain is very severe. We discussed in the beginning that a patient can present with back pain, number one, or they present with the radicular pain. If back pain component is very severe, then muscle relaxants can help to ease the back pain, which is happening because of the spasm of the musculature. It is only for a short duration of time to relieve the muscle spasm. And we should also remember that most of these muscle relaxants can also cause a bit of drowsiness. And in elderly patient, we should be very careful while giving these medications.
Thank you, Ajay. I will just want to reinforce what has been mentioned by both of you with regard to options of surgical management and pros and cons of each, and any indication for fixation and fusion per se. So surgical treatment depends on the morphology and the location of the herniated disc. It can be on one side, as is very often the condition, but sometimes, as was also mentioned before, you had pain traveling down both legs, or it may be in the center or in the foramen region. So various surgical options are present depending on both this morphology and location. So you have the traditional open discectomy. So this is most commonly these days indicated in large disc herniations with symptoms on both sides. Patients with a cauda equina syndrome with a central disc, and it offers a comprehensive clearance of the herniated disc material. However, it involves soft tissue dissection. You have to erase the muscles, which may cause blood loss, and there are chances of a prolonged rehabilitation period after the surgery because there is more invasiveness into this. So people have moved to minimally invasive surgeries where there are smaller incisions. The muscles need not be erased from their attachments. You just dilate the muscle over a guide wire with the help of dilators and put in a tube through which you operate, or you give a small incision and see it through a microscope and you operate. Ultimately, we have to understand that what is performed within is the same, whichever technique you follow. How you reach within is important. But if you need to see the disc on both sides, very often the surgeon would prefer to do an open discectomy. But otherwise, these days people have moved on to microscopic discectomy, endoscopic discectomy, or an MIS discectomy through tubular retractors. And when you go in for endoscopic discectomy, it may be an interlaminar endoscopic discectomy or transforaminal endoscopic discectomy. We won't go into the details of that, except that you need to know that a transforaminal endoscopic discectomy can be done in awake patients also. So, and it is minimally invasive again. So, we have to understand that ultimately the patient should leave the decision on the surgeon, so that the surgeon chooses the technique which he or she is most well versed with and which he thinks is most appropriate for the patient. Of course, this is a decision taken with the patient per se. As Ajay has mentioned, few surgeries may require instrumentation, especially if there is an instability. And if there is an instability, there will be pain, back pain or neck pain, which may be as much as the pain traveling down the leg or the arm. And that you generally see with dynamic x-rays, forward bending and backward bending x-rays. If the surgeon can demonstrate instability, then the surgeon will advise that I want to fix the spine in addition. Now, classically, when you go in for disc surgery in the neck or in the cervical spine, you go from the front and remove the whole disc. If you go in for discectomy in the lumbar spine, you go from behind and just remove the fragment of the disc which is pressing on the nerve. So, if you need to go in for a full discectomy in the neck, you then fix it even otherwise by putting in a cage and a plate, because otherwise there are more chances of scapular pain per se, which has been noted in literature. Here, rather than fixing, you can put in an artificial disc, what was called as a disc replacement. The positives are that it will retain movement at that level. There have been few studies which suggest that if you fix one level of the spine, more pressure comes on the adjoining segments, and this may result in more chances of failure of the disc at the adjoining segments, needing a surgery or management subsequently. And that's why disc replacement was born, to try to preserve movement. So disc replacement should only be done if there is some movement at the disc level on dynamic x-rays. Otherwise, that function will not be there. If there are some other contraindications for that, we don't need to go into the detail. But if you have such a problem when you visit your doctor, you should know that this is an option available. In the lumbar spine, lumbar disc replacement is less often used because you generally can do away with a small discectomy. And also, the complications of a disc replacement in the lumbar spine are far more than in the cervical spine, and the approach is not easy. So lumbar disc replacement is not so often used as a cervical disc replacement is used, but there are indications when it can be used and when it should not be used. I hope that is clear. If you have any queries in this regard, we could go in for it later. If we need to fix the spine, again, there are various techniques which are available. The one in vogue in the lumbar spine is a transforaminal lumbar interbody fusion. You do not need to retract the nerve roots substantially. You just go through the foramen, remove the whole disc, put in a cage, and fix it. You can go also from the front, but what is nowadays more often happening is an oblique lateral interbody fusion through a minimal approach, go through the front, because then you can recreate the normal alignment of the spine per se. So there are options available. Generally, if you go in from the spine, in the cervical spine, you'll go in from front and do it. But under certain indications, you may need to go from the back as well. I will come to Dr. Venkatesh once again and ask him, how can we reduce the chance of recurrence of prolapsed disc? And this should answer the question also of Vinitji. So, Dr. Venkatesh, is there anything specific which the senior citizens also need to take into consideration while trying to reduce the recurrence of prolapsed disc? Or I may want to add, to reduce the incidence of disc prolapse and back pain in general. So over to you, Dr. Venkatesh.
Yeah, as once we understand the natural history of the disc problem, So then we will know that why this happens and how we can reduce the recurrence. So the main thing is, as you know, it is a wear and tear. So what are the things which causes the wear and tear apart from aging? Apart from aging, what are the other things which can cause wear and tear is, most of the time it is the injury, the initial injury. So we have to avoid injury at all costs to the back. So what are the things which can cause injury to the back is, mostly it is associated with lifting heavy weights in some abnormal or awkward positions. So that was the initial thing that would have caused the disc prolapse, like trying to lift a weight without your knees bent, trying to lift directly, or trying to lift a weight on your head, which causes neck pain. So these are the things. Repeated hurt will harm you. So once it has harmed you, that is, it has caused that problem, we should make sure that we should not go back to the same thing again. So again, going back to lifting heavy weights or doing unnatural activities or activities which has caused the pain already. So these should be avoided, or it should be done in a proper way. So physiotherapists will tell you that how to lift a weight. Okay, it should not be that you should bend your knee. It should be as close to your body when you are lifting weight, and it should not be beyond a capacity where you can handle. That means if you have never lifted a gas cylinder, or say for example a water bucket, and if you have a back problem or a disc prolapse, you should not try those things unless it's an emergency. So you should be very careful. So try to avoid the thing which has caused you this problem. The second one is it's repeated, what do you call that, axial pressures. So what do you mean by repeated axial pressures is, like if you have the habit of jumping on a trampoline, or if you have a habit of going for gymnastics, that is, which includes jumping and twisting. So these things, when you have a disc prolapse, should be done very carefully, and preferably these should be avoided. So jumping and twisting and going and taking part in adventure sports when you have a disc prolapse should be avoided at any cost. And when you recover from this, you should again go back and see whether you are able to do it or not. And you should not overdo it. So that I'm not telling that don't do those activities at all, but you should not overdo these activities. Things like sitting on the floor, sitting cross-legged, or bending forward, or kneeling, as long as it is not going to cause you any problems, it's not a problem. You can do it. So you can sit cross-legged. Most of these people, in fact, senior citizens, when they have this problem, they'll be very comfortable on sitting on the floor. Okay, so, or bending forwards. So these people, they can do that. But sitting forward, bending forward, and lifting a weight, all these things should be avoided. So the main thing which usually causes the recurrence is the same incident which has caused you the disc prolapse when you're trying to do it again, or overdoing unnatural things like jumping, twisting, and bending forward and lifting weight. These are things which usually causes the recurrence.
Ajay, do you have anything to add to what Dr. Venkatesh has?
Yeah, I would like to add is like, if you are overweight, it's important that you reduce your weight, because one of the structures that support our back is the abdominal musculature. When we are overweight, the abdominal pot belly doesn't have any support to the spinal musculature. That's number one. Number two, be active to the limit of what you can. Do exercises regularly to improve the flexibility of the spine and the strength of the musculature which is around the spine.
So Ajay has also pointed out, reinforced in fact a very important point, the importance of the strong muscles of the body to reduce the chance of the pain bothering again and again, or the pain coming back. I think Dr. Venkatesh also mentioned in this regard, but this is common to back pain in general. So in the form, you should have a healthy lifestyle, and a healthy lifestyle generally incorporates general conditioning exercises like walks or treadmill, or gradually building up to aerobics, dance, swimming, jog, run, whatever you may want to do. But we have to understand that 7 to 8 decades ago, when men used to work in the fields, used to take care of animals, used to walk around, and women used to go to the well, would grind the floor, would take care of animals, go to the fields, take care of household activities. General conditioning exercises were inbuilt within the normal lifestyle, but they are no longer there. And as Ajay said, we need to add them to our lifestyle to keep strong muscles so that the chances of recurrence go down. Similarly, a good posture is very important, and it's not only a sitting posture, it's a standing posture, lying posture, working posture, which is very important. If you look at the spine from the side, as you can see in the graphic, there are curves within it. There is a forward curve in the neck, there is a backward curve in the upper back, there is a forward curve again in the lower back. And all these curves, if they are stretched, the ligaments and the muscles and the disc come under pressure, and the chances of back pain and a prolapsed disc increases. So one should learn how to sit properly, stand properly, lie properly, work properly, especially if that is over a prolonged period. So these are very important things which have also, in addition to the things which were mentioned by Dr. Venkatesh, to reduce the chance of the pain coming, disc prolapse happening, and to reduce the chance of recurrence per se. We have another question in the chat box, and I think it's being asked as to can pregabalin be taken for a prolonged period? So Ranjit ji has been taking it for 4 years. तो वो पूछ रहे हैं क्या मैं इसको कंटिन्यू कर सकता हूं? रंजीत जी, प्रीगैबलिन कई लोग 10-10 साल तक लेते हैं अगर जरूरत हो तो प्रीगैबलिन अगर खास तौर से जिनमें न्यूरोपैथिक पेन है, जैसे स्पाइनल कॉर्ड इंजरी में हो सकती है और बाकी में कई लोग लंबे अरसे तक भी लेते हैं, अगर जरूरत है तो ली जा सकती है। बट कभी कभी इसके अगर साइड इफेक्ट्स हो, जैसे कि वाटर रिटेंशन, रैशेस, कई बार साइकोसिस, तो फिर उस समय इसको चेंज करना पड़ सकता है, दूसरी दवाई पे आ सकते हैं। सो कमिंग टू द नेक्स्ट क्वेश्चन, and I will put that to Dr. Ajay first. What are the myths prevailing in the society about disc prolapse?
Actually, there are a lot of myths prevailing with regards to back pain and disc prolapse. Number one is the duration of bed rest. People pursue that anybody with the back pain should be in bed rest for a very long duration of time. We currently advise bed rest, if necessary, in an acute painful situation for maximum of a day or 2 or 3 to 4 days till the acute back pain subsides. That's number one. Number two, use of traction, which you already described, saying that we do not advocate use of traction in a patient with a back pain. It basically ensures bed rest because the force that is needed to distract is significantly higher and may not be possible with the usual type of traction that is being used. There is also myths with regards to what type of surface we should use to lie down, whether we should lie down on the floor, whether we should lie down on a hard mattress. Usually, it's enough if the patient lies down in whichever mattress they are quite comfortable with. Probably during the acute phase, if there is a spring mattress, it could be quite uncomfortable for them. But otherwise, a relatively firm mattress is all that is necessary. But having said that, if the patient is comfortable lying down on a floor or he is comfortable with that, we see a lot of patients who are comfortable with certain actions, with a certain things doing like that. It's okay. There's nothing wrong with that. But we do not advocate any particular beds that the patient has to use. You might have seen a lot of advertisement regarding the different beds that is available, and they are so expensive. It's not necessary. I think I would let Venkatesh answer the rest of the myths.
Yeah, Dr. Venkatesh.
Yeah, so I think Sarah has told about most of the myths, what the people routinely have. The main thing they usually come and ask is like this prolapse that I'm having this prolapse. Will my son get it, or will my daughter get it? Is it genetic? See, there are a lot of studies to identify the genetic problem of this disc prolapse, but nothing has been totally proved. So it can happen to anybody. Just because your father had or didn't have disc prolapse, that doesn't mean that you may or may not have disc prolapse. So it is an independent event. So you need not think that I am having disc prolapse or I don't have a disc prolapse and my children may or may not have disc prolapse. The next one is what kind of bed, as Sir said, to use is very arbitrary. Literally speaking, you have to lie down on a bed and see which bed is comfortable for you and use that bed. Generally, we advise that it should not be very soft, where it will arch your back backwards. So if you are going to, like, it will reproduce the thing like as if you are bending forwards. So this should be avoided. Soft beds, definitely firm mattresses, or sometimes people say that when I lie on the floor that I'm feeling comfortable. That's the whole thing, that when you lie on a firm mattress definitely helps, and there are no one specific mattress which has to be used. For neck pain, people used to ask, should I use a pillow or shouldn't I use a pillow? And it's the same thing, like this depends on where your disc has prolapsed in the neck. Okay, so if it is going to be more on the back, on the lateral aspect, when you keep your neck flexed, actually you feel more comfortable. So actually when you keep a pillow, it will be comfortable. When it is more in the center, when you keep your neck flexed, it is going to hurt you. So you have to try it and see which one is more comfortable, and you have to do it. Mind it that one hurt is not going to harm you unless it is very hard. But repeated hurts, that means repeatedly when you are going to hurt yourself, it is definitely going to harm you. So you have to read your neck and you have to read your back, because one person's treatment may not be suitable for other person's treatment. So every patient or every person needs a tailored treatment, which is not, it's not a uniform treatment for all.
Thank you, Dr. Venkatesh and Dr. Ajay. As you mentioned, there are many myths prevailing in the society. One is that imaging is required for all patients. Imaging may be required if you do not respond to treatment, but it is not mandatory. And let the doctor decide when imaging is required and prevent overuse of imaging per se, because patients with back pain of mechanical origin will often have normal X-rays. But when it is a prolapsed disc, again, many patients will have abnormal findings as such in the MRI or in the X-ray, many normal patients. And many patients with radiological abnormalities, as I mentioned, may be totally asymptomatic, and very often what you see on the imaging may not be responsible for the symptoms per se. And if you have any finding of the MRI, it is not mandatory that you need surgery to correct it. As we have discussed, most people will respond to a good conservative treatment. Gone are the days when they would say, if you have a prolapsed disc or back pain, stay on the bed for a month. You need to be on the bed. As Dr. Venkatesh said, you need to be in the bed only for the acute phase, only if you are not able to manage the pain, and if it is very acute, we want to be aggressive and have you out of the bed as early as possible, because we do not want your muscles to become weak per se. Another myth that was also talked about, stay away from surgery, has poor results and high complication rate. In fact, when a surgery is required, not going in for it can cause more serious problems and more complications per se than going in for the surgery. Surgery these days have become very safe, and especially surgery for disc prolapse is the basic surgery which any spine surgery does. When any spine surgeon does, the simplest surgery per se. Don't exert yourself. You should have restricted activities for life. You can never get back to a normal lifestyle. These are again some normal myths which are prevalent in the society. There are many others, like what was talked about, what type of bed, etc. you need to have per se. These are the myths which are there in the society. Now I will ask you, Dr. Venkatesh, there is a question in the chat box from Ritu Tayalji, and she has forwarded an MRI which reveals a diffuse annular disc bulge at L4-5 and posterocentral disc protrusion at L5-S1 together with facet joint arthropathy in buccal ligamentum flavum, indenting thecal sac, causing bilateral neural compression with critical canal stenosis. What is your treatment? She has been requesting repeatedly. Before you speak, I think you would agree with me that management doesn't depend on the MRI alone. Many people, as we talked about, will have findings in the MRI but no symptom. So Ritu Tayalji, we need to know your symptoms in order that we can manage you properly. But
Yes.
Dr. Venkatesh, if Ritu Tayalji has pain traveling down the leg with such an MRI picture, what would be the treatment that you would suggest to her?
Yeah, if I assume that she is around in her 4th decade or 5th decade,
45 years of age.
yeah, 45 years of age, and she's quite active at home, and she has had this problem for quite some time. And if she has undergone a good conservative management in the form of medications, exercises, modifying her lifestyle activities, I've seen the MRI. So with all these things, if she's still symptomatic, I would go for semi-invasive procedures like root blocks and facet blocks on these patients.
Great. So, Rituji, as Dr. Venkatesh also said, if you have not responded to a good, appropriate, conservative treatment, root blocks or facet blocks would be the treatment that he would advocate. However, we need to know more about your symptoms and more details. You can mail to any of us and we will get back to you with the detailed management plan. Please describe your symptoms in detail and the treatment that you have taken so far in detail so that we can get back to you. We are coming towards the end of the webinar. If I don't see any other questions in the chat box. I hope I have not missed any. If anybody wants to ask a question verbally, please quickly raise your hand and we'll get back to you. There is another question from Nehar Singh ji. He had been suffering from back pain. He responded to medications, but the pain came back again. And after he had responded very well, and he apparently has not responded well to the conservative treatment. Nehar Singh ji, we would suggest that if you have tried everything that has been described to you properly and appropriately, then our next suggestion, as Dr. Venkatesh also suggested, would be to go in for a nerve block or a transforaminal epidural steroid. You also have the option to go in for a surgery if you do not want the injections, if you are bothered substantially. So get back to us with more details and we will let you know further in this regard. So I don't see any other questions. There is a hand raised by Ranjit ji. Ranjit ji, please pose your question. आप अपना question पूछ सकते हैं अभी. Unmute करिए अपने आप को.
नमस्कार जी सर. सर 4.5 साल हो गया ऑपरेशन का.
हाँ जी.
सर कुछ मूवमेंट भी आए थे लेग में. उसके बाद अभी जो है सर ऊपर से कमर से लेके पांव की तलवा तक राइट में, लेफ्ट में नहीं होता है पेन, राइट में बहुत भयानक पेन होता है और टाइटनेस भी आ रहा है.
तो अगर मैं आपको ठीक समझ सका तो मूवमेंट नहीं आया तो ये एक स्पाइनल कॉर्ड इंजरी थी. वो एक डिफरेंट सिनेरियो होता है. वो प्रोलैप्स डिस्क अलग चीज होती है. तो आपको जो पेन है उसको हम न्यूरोपैथिक पेन कहते हैं. जो जहां सेंसेशन ना हो वहां भी पेन हो तो उसको न्यूरोपैथिक पेन कहते हैं. इसमें नॉर्मली हम जैसे प्रीगैबलिन और जरूरत पड़े तो डुलॉक्सिटिन और जरूरत पड़े तो एमिट्रिप्टिलिन की दवाइयां देते हैं. और अगर एक अच्छे कोर्स में और टेंस थेरेपी में आप नहीं रिस्पॉन्ड करते और 4 साल से पीड़ित हैं तो एक ऑप्शन इसका स्पाइनल कॉर्ड स्टिमुलेटर होता है. तो आप जरूर अपनी डिटेल्स हमें लिख के भेजें. तो और या हमसे आप वार्तालाप भी कर सकते हैं फोन पे, तो हम आपको और डिटेल में बता पाएंगे. ये वेबिनार प्रोलैप्स इंटरवर्टेब्रल डिस्क का डिस्क प्रोलैप्स आपका उसके दायरे से बाहर है, बट हम आपको जरूर मदद करेंगे इसका क्या इलाज हो सकता है, ठीक है?
थैंक यू।
So I don't see any other raised hands. I would want to first ask Dr. Venkatesh, what is your carry home message for the participants, for all those listening to this webinar and participating in it?
I think when you have a disc prolapse, like you should keep yourself active, do regular exercises, and keep a track on your weight. I think these are three main things which I would say that if you are diagnosed to have it, please make sure that you keep yourself active, don't hurt yourself, but keep yourself active and also keep a track on your weight.
Thank you, Dr. Venkatesh. Very important points and very important to reduce the chance of recurrence. First, important to have back pain or a disc prolapse. This is important in reducing the chance. And if you get it, it is very important to reduce the chance of a recurrence. Thank you. Ajay, would you want to add to that? What would your carry home message be for all participants of this webinar?
First important thing is not to think that, we see a lot of patients who think that they've got a back pain and most probably most of their active adult life will become difficult. It's not like that. With the majority, even though you have a disc prolapse, you can still lead a normal life. Majority of the patients will become better with conservative care. Very few of them will need surgery. And once you become better, following the acute episode, it's important to be active, stay slim, and to do exercises regularly.
Thank you, Ajay. Very important carry home message. I can see Bipin Singh ji has raised his hand. So please अपने आप को अनम्यूट कीजिए और जो आपका सवाल है वो आप पूछ सकते हैं किसी भी पैनलिस्ट से. बोलिए.
गुड इवनिंग सर.
हाँ जी बोलिए, आपकी आवाज नहीं सुनाई दे रही विपिन सिंह जी.
गुड इवनिंग सर, मैं विपिन सिंह बोल रहा हूँ सर.
हाँ जी नमस्कार.
नमस्कार सर, मैं आप ही का पेशेंट हूँ सर.
हाँ जी विपिन जी. फाइनल इंजरी हुई शायद आपको.
हेलो सर, मैं कह रहा हूँ जलन नहीं सर कंट्रोल हो रही. 4 साल हो गया, 5 साल बराबर ले रहा हूँ प्रेगाबिड और डुवांटा वगैरह, उससे सर कंट्रोलिंग नहीं हो रही जलन की.
दर्द काफी है. प्रेगाबिड आप 600 मिलीग्राम तक भी धीरे धीरे बढ़ा सकते हैं. डुवांटा 120 मिलीग्राम तक जोड़ सकते हैं. अगर जरूरत पड़े धीरे धीरे बढ़ाइएगा. जरूरत पड़े तो ट्रिप्टोमर 75 मिलीग्राम, एमिट्रिप्टलिन 75 मिलीग्राम तक जा सकते हैं. और अगर सारे में ना आराम आए तो जरूर हमसे फोन से या मेल से संपर्क कीजिए. हमारे पास इसके और भी उपाय होते हैं. एक उपाय जैसे बोला, अगर पूरे इलाज से आराम ना आए, काफी पेन से पीड़ित हैं, तो स्पाइनल कॉर्ड स्टिमुलेटर का ऑप्शन होता है. पर आप टेंस थेरेपी जरूर ट्राई कर लीजिएगा. ये एक मिथ है कि जहां छूने का एहसास ना हो वहां टेंस थेरेपी नहीं असर करती. टेंस थेरेपी वहां भी असर कर सकती है. तो टेंस थेरेपी जरूर करवा के देखें. खरीद के घर में भी आप कर सकते हैं. तो जरूर अगर आपको आराम ना आए तो हमसे संपर्क करिएगा किसी भी पैनलिस्ट से. ब्रिजेश अग्रवाल जी, इफ यू हैव अ क्वेश्चन प्लीज आस्क इट. प्लीज अनम्यूट करके आप क्वेश्चन पूछ सकते हैं. ब्रिजेश अग्रवाल जी.
नमस्कार साहब, मेरी आवाज पहुंच रही है?
हाँ जी.
हेलो. हाँ डॉक्टर साहब, ये मेरे पिताजी की L4 और L5 में दिक्कत थी पिछले 4 साल से.
हाँ जी.
तो आपके द्वारा सर्जरी हो गई थी उसकी.
हाँ जी.
लेकिन अब इनको थोड़ा दर्द रहता है, थोड़ा सा चल फिर लेते हैं उसके बाद.
दर्द कमर में है, पैर में है?
हाँ
कमर में दर्द है.
कमर. हाँ.
ये समझना बहुत जरूरी है कि जो ऑपरेशन होता है वो पैर के दर्द के लिए होता है, कमर के दर्द के लिए जनरली नहीं होता. तो अगर आपको दर्द तंग करती है कमर का, सेक करें, मलहम लगाएं, दवाई लें. पर यह जरूरी है कि अपने मांसपेशियों को मजबूत करें टहलने की आदत से, कमर की वर्जिश से, और पोस्चर ठीक रखें. ना आराम आए तो जरूर हमें मेल लिखिएगा या आप फोन कीजिएगा और हम जरूर आपकी जो परेशानी है उसको दूर करने में मदद करेंगे।
मलहम में क्या लगाना था?
मलहम कोई भी, इतनी सारी मलहम होती है ना जो बाजार में मिलती हैं जो दर्द के लिए, कोई भी यूज कर सकते हैं आप उसके लिए। ठीक है जी। तो
कुछ सिकाई कर सकते हैं?
हाँ जरूर कर सकते हैं, सेक कर सकते हैं, मलहम लगा सकते हैं, दवाइयां ले सकते हैं, फिजियोथेरेपी करा सकते हैं। So friends, we are coming towards the end of this webinar. Just to reinforce the carry home message, disc herniation is common in the general population. A healthy lifestyle helps to reduce the possibility. A healthy lifestyle which includes appropriate general conditioning exercise and good posture. If, however, it occurs, most of them can be managed conservatively. Apart from medications, general conditioning exercise and good posture and exercise are important to reduce the chance of recurrence of the symptoms. Nerve root injections are an effective treatment option if the conservative treatment fails. The only absolute indication for surgery is involvement of bowel and bladder control. The most common indication of surgery is a failure of an appropriate conservative treatment. However, surgical options include traditional open and minimally invasive endoscopic discectomy of the fragment causing the nerve root inflammation. In a very few cases with spinal instability, fixation and fusion is required in addition to discectomy. Friends, this webinar has been brought to you by Spine Wellness and Care Foundation. Of course, we are thankful to our panelists, Dr. Venkatesh and Dr. Ajay Shetty, who participated in the webinar. Spine Wellness and Care Foundation is a charitable non-governmental organization established for improving the wellness of people with spinal ailments in India. We reach and serve persons affected with spine-related ailments medically and socially to help them lead better lives. Our main objective is to provide medical, rehabilitation, vocational, recreational, and social support for persons affected with spine and related ailments. You can reach us to our website, through the email, through Facebook, YouTube, and Instagram. Friends, our next webinar would be on lumbar canal stenosis. Again, a very common situation, especially in the elderly, but sometimes also in the young adults who have a narrow canal since birth. And we thought it may be worthwhile to change the timings to Sunday from 11:30 a.m. to 1 a.m. So we will have it on Sunday, the 16th April, the next webinar. Friends, it is in our hands to create a better world for all who live in it. Come, let's join hands to improve spine wellness and care and to alleviate the burden of spine disease. Let's start with ourselves by incorporating sufficient general conditioning exercise in our lifestyle and maintaining a normal posture. Thank you for your patience. We will look forward to having you again. And once again, I thank wholeheartedly Dr. Venkatesh Krishnan and Dr. Ajay Shetty for taking out their very valuable time and participating in the webinar today. And as you can see, we have prevented Dr. Venkatesh to go back home from the operation theatre. He's still stuck in the theatre. Dr. Ajay Shetty is also a very busy spine surgeon. So thanks to both of you for having taken out time. Thanks to all the participants for being patient. We have tried to get back to your questions, but if there are any, please mail them across to us and we'll get back to you. Ankita Goswami ji wants a last minute question, to put across a last minute question. Ankita Goswami ji, we respect.
Dr. Saab, namaste.
Yeah.
Dr. Saab, namaste.
Please, हाँ जी,
नमस्ते. Dr. Saab, मेरा
पूछे.
कल्याण सिंह बोल रहा हूँ मथुरा से. डॉक्टर साहब.
हाँ जी, पूछे कल्याण सिंह जी. कैसे हैं?
मेरा ट्रीटमेंट किया है काफी समय में.
हाँ जी, कैसे हैं आप?
हाँ, मैं ठीक नहीं हूँ, मुझे खड़ा नहीं हुआ जाता है, मांसपेशियां बहुत वीक हैं और पेन रहता है मेरी बॉडी में हर वक्त।
ठीक है, आपकी दिक्कत गर्दन में थी कि कमर में थी?
कमर में से।
कमर में थी, तो आप जरूर अपने डिटेल्स हमें भेजेंगे। आप हमें व्हाट्सएप भी कर सकते हैं, मेल भी कर सकते हैं, और
जी,
हम जल्दी
जी।
आपको वापस बताएंगे। आज ही भेजिए ताकि हम आपको जल्दी वापस बताएं। ठीक है?
जी, जी,
अंकिता
बिल्कुल,
गोस्वामी जी,
हाँ बोलो।
Yes, sir. He's my father only.
आप अच्छा, आप उनके बारे जानना चाहते हैं? प्लीज, आप ईमेल यूज करते होंगे, ठीक
Yes,
है?
sir. Yes,
तो
sir.
प्रिस्क्रिप्शन पे ईमेल दी होगी, फोन नंबर भी दिया होगा। आप जरूर
Okay, sir.
डिटेल्स जल्दी भेजें और हम आपको जल्दी इसका जवाब देंगे।
ये मेरी
Okay,
बेटी है डॉक्टर साहब,
हाँ
बेटी
जी,
है ये मेरी।
नमस्कार जी, नमस्कार। जरूर हम
और
आपको
अभी ये
हाँ जी, जरूर हम आपको जल्दी वापस जवाब देंगे। एंड थैंक्स टू दोस्त डॉक्टर कोमल कामरा, Dr. Mathur and others, including Vineet ji, who have found the webinar useful and have appreciated it. Thanks to all of you, and we look forward to having you again. Good night and have a nice weekend.
Good night.
Thank you.
Thank you.
Thank you.